Well, hello, and welcome to a lecture-type discussion of some of the surgical pathology issues that arise as we examine the appendix. Certainly, the appendix is one of the most commonly examined surgical specimens, and so therefore, it's incumbent upon every pathologist to be reasonably familiar with the entities to be encountered here. Even though acute inflammatory disease is the most common disorder, there are many other variations on that theme, as well as a variety of neoplasms that, though less frequently encountered, need to be recognized. So we'll talk first about the non-neoplastic lesions. Fairly trivial lesions like fibrous obliteration or diverticulum. These are not particularly germane to major diagnostic considerations, but do arise and should be recognized. Acute appendicitis, of course, is the hallmark disease that leads to resection in most cases. There also is some debate about whether or not chronic appendicitis can occur, but with recent studies showing successful treatment of acute appendicitis using antibiotics and other means, it's not unlikely that we might see some chronic appendicitis. Periappendicitis, those sorts of things. Endometriosis and other sorts of changes related to the proximity to the gynecologic tract is certainly also to be encountered on occasion. Gliomatosis, less frequently, but might raise consideration of ovarian teratoma. And of course, inflammatory bowel disease is always a potential indication or cause for inflammatory symptoms and things that may lead to resection. Then there are the specific infections, whether they be viral, parasitic, or bacteria. So let's just look at those briefly. Bacterial infections, Campylobacter, Yersinia, Actiniomyces, those sorts of things we might encounter here in particular populations. Malakoplakia, probably infectious and certainly has some hallmarks of infectious type disease in terms of the granulomatous or histiocytic response. Spiroketosis, not typically a symptomatic infection, but can be present, manifest as a pronounced deposition of spirochetes along the brush border of the mucosal epithelial cells. Fungal, parasitic infection, particularly anaerobius, can be encountered in the appendix. And then a few viral disorders that are perhaps dependent on location and age group and so forth. Epstein-Barr virus, perhaps the most critical one. So just be aware of those. Let's move on and talk about the fun stuff, the appendix, the neoplasms that can arise here. And this presents us with some challenges in terms of nomenclature and terminology that can be quite variable. So there are a host of mucinous neoplasms and a host of names that have been used, ranging from mucocele to adenoma. And of course, when we encounter spread in the form of pseudomyxoma peritonei, metastatic mucinous carcinomas, and so forth. And then the grading of these tumors has presented some problems in the past. We have a variety of neuroendocrine tumors that also occur in the appendix, fairly frequently encountered. And then there are those of mixed differentiation, goblet cell carcinoid, and what was previously called MANEC, but now is called MINEN, mixed neuroendocrine, non-neuroendocrine carcinomas. So just to give you an example of where some of the issues lie, this is a graphic showing several different classification schemes that have used differing terminology for different kinds of tumors. So if we just look at those that are confined to within the appendix, most people have called those adenomas, and the World Health Organization vowed to that, but some people will still use that as a low-grade appendiceal mucinous neoplasm. And notice that that term can also be applied for those that have pushing invasion. Now, that's a useful term. But along with that, one would think we need to provide some of this additional information about whether it's confined, whether there's mucin outside the appendix, whether there's tumor cells outside the appendix, because in some schemes, those can still fall into the same rubric, but have somewhat different prognoses. And then there are those that have infiltrative invasion, where the more conventional term adenocarcinoma is used. Now, in fact, I think in terms of staging and cancer registries and so forth, these lesions are considered malignancies in most settings. Let's talk about adenomas in the appendix. So conventionally, these are both tubular and villous type architecture and have the demographics and so forth that one would associate with other adenomatous lesions in the large bowel. They do have KRAS mutations, as seen elsewhere, but the symptomatic presentation is distinctive. They may present as acute appendicitis or a mass lesion or those sorts of things that would be slightly different from normal adenomatous lesions elsewhere in the tubular tract. So here's an example. We can see the nice villous architecture of this with abundant epithelial mucin and some crowding of the epithelial cells at the base of the cell. Relatively mild or minimal dysplasia, though there is crowding, and these cells, if you examined closely, you would see the elongated and somewhat cigar-shaped, pencil-shaped nuclei that we associate with adenoma. But sometimes this change can be fairly subtle, and not everyone is keyed in to recognize it. So when you see loss of the normal lymphoid component of the appendix, that should be a clue to look. And you can see here that you have this change throughout, but only focally do we see this sort of low villous type architecture manifest in this full cross section. So that's a challenge. And many times these will not have high-grade dysplasia, though that can be present. Here we see almost some signet ring type cells being formed here as well. So let's talk more about low-grade mucinous neoplasm of the appendix. This can present in a very broad range. Again, females are more frequently found to have this lesion. Essentially, the definition, at least as promoted in the CAP checklist, is that of an obliterated muscularis mucosa that has epithelium resting on a fibrous tissue base, or with non-destructive mural and peritoneal involvement, such as might happen after a rupture or something of that sort. Now, I point this out, obliterated muscularis mucosa, because not all sources will quote quite the same definition. In fact, we've quoted from another source later that has a different wording, which will be interesting to pay attention to. Sometimes this lesion can present as an ovarian mass. Sometimes it's just an incidental finding at the time of colectomy for other reasons. And again, these are associated with KRAS mutations and in a fair number GNAS mutations as well. So here's an example of the gross type of image one might expect to see: a dilated lumen, sort of a glistening surface, pale, slightly discolored, and some degree of mural thickening, as you can note here. Here's the microscopic correlate to that, and you see this mural thickening is manifested as sort of a fibrous hyaline scarring and a little bit of villous low-grade architecture here. So this qualifies as a low-grade appendiceal mucinous neoplasm because of this fibrosing change here. And we'll look at that at higher magnification. Here we can see this very dense hyaline-type cartilaginous tissue, not a normal lamina propria. So lacking a normal lamina propria, we would not call this an adenoma. We would call it a low-grade appendiceal mucinous neoplasm. Now, to give you an idea of how this can spread beyond the appendix, here's a nice example showing a hole cut mount with a focus of apparent rupture with spread of the mucin and potentially epithelium out onto the peritoneal surfaces. And in this situation, identification of epithelium beyond the appendix is a critical finding. So that needs to be carefully sectioned and looked for. One thing to be aware of is that the pushing invasion does not produce the same kind of desmoplasia that we associate with destructive invasion. This hyaline fibrosis that we've just illustrated with low-grade appendiceal mucinous neoplasia is not desmoplasia. It's a hyaline fibrosis. And so when you see mucin or epithelium in the wall or beyond without destructive invasion and low-grade cytology, we can still classify that as low-grade appendiceal mucinous neoplasm. And similarly, when you see such cells in the ovary, in the presence of a mucinous neoplasm in the appendix, that by convention and most likely by biology is interpreted as arising in the appendix, even if no perforation is seen. So that's an important caveat and one of the places where GYN and GI pathology come together. Now, the differential diagnosis of this lesion can include a retention cyst, which should have both an identifiable muscularis mucosa and some degree of lamina propria. And so here you see that. There's a lot of mucin in these cells, but we still have a little bit of lamina propria, and here's the muscularis here. So it would not qualify. Likewise, a ruptured diverticulum can give you a mucinous reaction on the serosa and so forth, but you should not have the evidence of low-grade appendiceal mucinous neoplasia, such as we've just indicated, loss of the lamina propria, hyaline fibrosis, and any degree of cytologic atypia. Now, there are a couple of clues that can help you to figure out that that's what's happened. Certainly, multiple diverticula, some of which were intact, would be an indicator that maybe this rupture was not due to neoplasia. If you see mucosal hyperplasia with preserved crypt structures, that's helpful. Chronic inflammation, fibrosis, well, yes and no. And then this mucosal neuromatous change, which we've illustrated here with this very fibrillar type of neuroma type tissue, that is also a good indication of diverticular disease and mucosal rupture damage. So how do these low-grade mucinous neoplasms behave? Well, that is in part dependent upon the extent of the epithelium that's outside the appendix. And certainly you want to sample it so thoroughly that you can speak confidently and say that it is all low-grade. You don't want there to be any high-grade areas. Generally, if it's just mucin in the right lower quadrant, they're going to do quite well. If there's epithelium and mucin beyond that, then they may warrant more aggressive treatment. And that treatment can include localized treatment or treatment to debulk, resect, or potentially even include heated intraperitoneal chemotherapy or HIPEC. So when we speak about frank carcinomas of the appendix, those can be typical adenocarcinomas not otherwise specified, or more frequently are mucinous carcinomas. And those definitely should have more than 50% mucin. These are prone to rupture, just as low-grade appendiceal mucinous neoplasms are, and they may have signet cell morphology. But other morphologies are also possible. Undifferentiated tumors, medullary, adenosquamous, and then the neuroendocrine carcinomas, either of large or small cell type, can likewise present in the appendix. So these are much less frequent. Here's an example of an invasive mucinous carcinoma. You can see abundant pools of mucin here in the wall and ample amounts of epithelium with an overlying typical tubulovillous adenoma, perhaps with high-grade dysplasia on the surface. More diffuse types of carcinoma can also be present with some variation of mucinous differentiation and pools of mucin with cells. but you should also look to see if you have a diffusely infiltrative pattern of neoplastic cells, as we see here in the submucosa. Higher magnification would allow you to differentiate and identify these as clearly malignant cells rather than just inflammatory cells. Now, when we get to the point where we have pseudomyxoma or extensive peritoneal involvement by mucin, that may occasionally lead to resection, as in this specimen, showing these multiple nodules of glistening type mucinous epithelium. And again, these can be the setting for both low-grade or unequivocal carcinoma. So low-grade appendiceal mucinous neoplasms can have lots of pools of mucin, very low cellularity. We see virtually no epithelial cells here, maybe a few here and there. And then at higher magnification, we might again find this fairly low-grade epithelium resting on a dense hyaline fibrous membrane, as you see here. So the term high-grade appendiceal mucinous neoplasm has been used in the past. It's not included in the current WHO, although there are some publications out there. And to quote one publication, without giving names, but one reputable source, this has been defined as a pushing front of neoplasia with dissection outward into the muscularis mucosa, but confined by the muscularis propria and lacking an infiltrative growth pattern, destructive invasion, or stromal desmoplastic reaction. So you see here, it's very easy to be confused in the literature because the definition of these terms and their usage can be confusing to some readers and some sources. I think this term, confined by the muscularis propria, is best omitted and should probably not be used as something that you would use as a criteria in defining this lesion. Peritoneal mucinous adenocarcinoma will have, of course, high-grade epithelium and generally more abundant cellularity, although sometimes after treatment, cellularity can certainly go down. You can consider other sites such as the urachus, gallbladder, colon, pancreas, stomach, and so forth, but these are less common than would be seen in the appendix. Oops, let's erase our mark there. Okay, so this gives you an example of high-grade appendiceal mucinous carcinoma, high degree of anaplasia here in this tumor, and certainly surrounded by mucin. You'd have no difficulty recognizing this as mucinous adenocarcinoma. So in terms of treatment, we've mentioned surgical resection. Generally, if it's identified in an appendectomy specimen, even if there are negative margins, a hemicolectomy will offer improved 5-year survival. And in patients with existing ovaries, consideration might be given to prophylactic oophorectomy. And occasionally patients will come to debulking therapy, peritonectomy, or chemotherapy in the form of HIPEC is considered as well. So let's come back a little bit and talk about some of the other polypoid lesions or precursor lesions that may be encountered in the appendix. These include the serrated lesions. These are not that infrequent and not infrequently can be overlooked. The most common of these is the sessile serrated adenoma or lesion, most without dysplasia. Occasionally there is dysplasia. Traditional serrated adenomas have been reported to occur in the appendix, but are quite rare. That's usually a left-sided lesion in the colon. And again, those can have either conventional dysplasia or not. Hyperplastic polyps or mucosal hyperplasia also exist. There is a form here and has been described as sort of a diffuse hyperplasia. seen in the setting of perhaps increased mucin in the lumen without deep glandular dilatation. So in that situation, you might make the diagnosis of diffuse mucosal hyperplasia with increased mucin production. But I would certainly want to make sure we'd sampled it thoroughly to eliminate the possibility of serrated type adenoma, which I believe would be more frequently encountered. Here's an example of that, and here you can see the characteristic deep glandular dilatation. Here's a you know, Charlie Chaplin foot type of configuration, more deep glandular dilatation, and conventional serrated type architecture, almost becoming villous in some areas. As noted, these can have some associated degree of dysplasia, and here you see loss of mucin and more conventional dysplasia over here on the right side with the beginnings of a more complex architecture. Traditional serrated adenoma, you'd like to see the microcrypts and villous architecture. This has a little degree of dysplasia, but does not really demonstrate well the microcrypts or ectopic crypts that are characteristic of traditional serrated adenoma. Neuroendocrine tumors, something that everyone should be familiar with if they're going to do surgical pathology. You're going to see these in your experience. Even though they're a small percentage of resected appendices, you multiply this over your career of examining maybe 10,000 appendices, and you're going to see some of these. Women, again, more frequently involved, and typically these do not produce the carcinoid syndrome. Most of them are in the distal tip, and that's the importance in terms of sampling, to make sure that you sample the distal tip, usually with a bivalved on kind of coronal type section. Lymphovascular invasion or mesoappendiceal spread are relatively common, and size, of course, is an important predictor of future behavior. Here's what these might look like grossly, if they're visible at all. Very often they're just incidentally located, but they can have this sort of yellowish appearance and show the configuration of that tumor. Microscopically, these are not particularly diagnostic problems. They may have the sort of insular type of pattern, islands of cells in a background, but they can also have very typical, round nuclei, salt and pepper chromatin, lack of any prominent nucleoli, low mitotic rates, and so forth, characteristic of low-grade neuroendocrine tumors. Sometimes you'll have clear cytoplasm, sort of a balloon cell type of change, as seen here. And other patterns of growth, such as this more tubular pattern with slight glandular type formations, can also be seen. Now, a confounding challenge is the goblet cell carcinoid, which is a combination of both an amphicrine tumor with neuroendocrine and epithelial type features. So this is, again, usually incidental. It's small, not grossly evident lesion. But these lesions typically have more carcinoid-like features rather than carcinoma. So even though you see mucin production or goblet cells, or maybe even signet ring cells, these typically have gastrointestinal type markers, CDX2, CEA, maybe CK7. These lesions can metastasize. This is not a totally benign disease by any means. And it's the beginnings of a topic that is evolving in the literature. So here's an example of a goblet cell carcinoid. And you can see the nice mucin producing cells, goblet cells, almost signet ring type forms. And were you to do neuroendocrine markers, you'd see that as well. And here's a nice slide showing you no neuroendocrine markers here, sorry. So the goblet cell carcinoid, here you can see the granularity in some of these signet cells that is characteristic of the neuroendocrine granules. You can see that granularity to there. somewhat resembling Paneth cells. So this introduces the topic of the mixed neuroendocrine, non-neuroendocrine carcinomas, previously known as manic or neuroendocrine adenocarcinoma, but now revised to mixed MINEN, mixed neuroendocrine, non-neuroendocrine carcinomas. And they form a spectrum that can go from just the goblet cell carcinoid, which would be the typical example, to varying degrees of differentiation and malignancy. The carcinoma can present as a variety of types, including the signet ring cell types or discohesive types, or more conventional gland-forming tumors, maybe even medullary or undifferentiated type tumors, and even some high-grade neuroendocrine carcinomas or undifferentiated tumors. And so for this reason, we don't use the mixed neuroendocrine adenocarcinoma term. We use the mixed neuroendocrine, non-neuroendocrine carcinoma to remind ourselves that this can be any of a variety of tumor types. Here's an example. You can see here in this upper right, formation of a nice, very pleomorphic nuclear features of a typical carcinoma. And other areas, a more diffuse pattern, as you see here. And then here, sort of a variation on the that pattern, lower magnification of this more infiltrative type carcinoma. Ideally, you want to see both some degree of neuroendocrine differentiation and clear-cut carcinoma. Although previously people have used the 30% cutoff, requiring that you have at least 30% of the tumor composed of one or the other of those elements, I don't think that's a totally hard and fast rule if you've got a substantial portion. You can see sometimes single file infiltration with these tumors, poorly cohesive tumors that are going to behave, or you can have a more conventional type adenocarcinoma with areas not seen in this image that would be more typical, well-differentiated neuroendocrine tumor. And here's a more neuroendocrine type area resembling neuroendocrine carcinoma. Again, ideally, you've got the immunohistochemistry to back up the fact that you've got a biphenotypic pattern where some areas are clearly expressing neuroendocrine markers and others are not. So let's leave that topic, and you can read some of the literature on this evolving area of appendiceal pathology at your leisure. Let's just talk about what we report with these tumors. And here it's important to note that there are 2 CAP checklists for the appendix. Probably the smallest organ in the body that has 2 checklists. Of note here is that these mixed tumors are reported under the carcinoma checklist. So we have the neuroendocrine tumor checklist and the carcinoma checklist, but in both, many of the same features are noted: size, site, specimen type, spread, lymph node status, margins, etc. And then in the neuroendocrine tumors, we would want mitotic rate and Ki-67 scoring. So these have been updated. There's a 2020 update, and I would refer you to pay some attention to the notes in these protocols, which are always very helpful in terms of assessing the significance of a particular prognostic factor. Well, that's it for a short run through the appendix and some of the surgical pathology issues we encounter there. I hope this has been useful for you. Please subscribe and add comments below, and if it's something we can help with, we'll be happy to respond. And we hope that you'll join us again at a future point during one of our sessions. So thanks again, and we'll see you next time.